Hey folks, Scott Weingart here, and this is the EMCrit podcast. And in fact, this is an EMCrit podcast I'm super excited for. I have Dr. Sheldon Cheskes, who was the lead author of the DOSE-VF trial, on the show in just a few moments. And I wanted to delve into all things defibrillation. Since the DOSE-VF trial, for those not familiar, that's a study of dual sequential external defibrillation versus standard or vector change. And it was the trial that actually showed that DSD actually works. Amazing trial. But then even more interesting to me, multiple secondary analyses have come out that really provide interesting stuff. So I'm glad that we have done this interview at the time we did, because there's so much intriguing things that came out after the trial that we really need to discuss. We will get to that interview shortly. Just some terminology you may hear. DSED, which is what you'll hear this referred to as throughout the show, is dual sequential external defibrillation. I've always called it just DSD, which is dual sequential defibrillation. The external, I guess, is to contradistinct it from internal defibrillation, but DSED is what we'll talk about. You'll hear about discussing pad positions, AP versus AL, and AP is anterior posterior and AL is anterior lateral. And let's see, is there anything else you really need to know? Dr. Cheskes has a conflict of interest. In addition to taking grants for his studies, which most of the researchers are doing, he is on the Speakers Bureau of Zoll. So, as a result, I will not be offering continuing medical education for this episode. Early next week, I will put up another episode that the members, you all should be members, some of you aren't, but you all should be members, that the members will get their CME in lieu of this one. So this one, while it is a podcast, there won't be CME offered. And early next week, there'll be an episode where you could get your CME and fill in that blank, so I'm not shortchanging you in any way. All right, let's do a quick mention of something really important to me, and then we will get into the show. All right, here's what I want you to know. Reanimate 11 tickets are now for sale. Reanimate is our resuscitative ECMO conference with VA ECMO, eCPR, Crash VV ECMO. It is in San Diego every year. It is November 12th and 13th, and it sells out rapidly every single year. Every single year, I keep doing these ads. People are like, I'll wait. And then they decide to buy their ticket 2 months beforehand, and we have none. And they're like, oh no, I wish I really wanted to come this year. I'm like, yeah, then you should have done it when I talked to you in January. So if you want to come to Reanimate, now is the time to buy your tickets. Go to reanimateconference.com. That's reanimateconference.com. Buy your ticket, and then you will not miss it again this year. All right, let's get to the show. Who are you and what do you do? Just for the audience that may not know.
No, for sure. So I'm Sheldon Cheskes. I'm a medical director and a professor of emergency medicine here at the University of Toronto. I'm a resuscitation scientist, and that's really my area of research. I really focused for years on the areas of CPR quality in my early career, and now really most of my time is focused on defibrillation since the publication of DOSE-VF.
Yeah, I was about to mention, you're also the primary investigator and lead author of DOSE-VF, a study we've talked about numerous times on the show because it was such stellar work, really just gave a research backbone to something that all of us were super excited about, but really didn't have enough evidence to push. And now we do. So thank you for that. Fantastic work. And we're going to delve into some of that. The first question I have is, research and clinical training in this area has consistently been hindered by poor descriptive terms. So I really want to nail the terminology up front. So the way I have always used these words, and I think the way you use them as well, is refractory, aka in my mind, electrical storm, is VFib that never shocks out. You administer the energy, they're still in VF. And then for me, recurrent was always you shocked them, they had a brief period of PA or asystole, and then they went back. But your research now, there's a third group, which is they're allegedly refractory, but when you actually look at the waveforms, there is a brief, non-discernible to the medics period of shocking out and shocking back in. So now the words again are completely up in the air. So tell me, should we be calling these things, these three groups, and how do you think about them?
Yeah, we used a pragmatic approach. I think a pragmatic approach was what most clinicians care about most is, what the hell is a rhythm after 2 minutes of CPR? That's what I'm looking at. You can talk all about see-through CPR and all these filtering techniques that people have that give you an idea of the waveform in between shocks. But at the end of the day, there's no protocol that says, okay, if you see VF early after shock, you should shock it again. So what we used was a pragmatic approach. Patients present in VF, And after each of the 2 minutes of CPR, they're still in VF. And that's really easy to do, right? It's really pragmatic. The paramedics can do it, and any clinician can do it well. If you try to use a more EPS point of view, so patient presents in VF and just stays in VF the whole time versus recurrent where they come out of it and then go back into it, that requires you to stop, take a look at the rhythm, print out the rhythm. And at the end of the day, what do you do with that? There's no protocol that says shock early or not shock early. So we used a pragmatic approach. I think that's a very sensible approach. And from an EPS point of view, the refractory versus the recurrent, this is something that we addressed in some of our secondary work that we published about a half a year ago. Then we really closely look at the mechanism to see why should DSED make a difference in refractory versus recurrent VF.
Now, Sheldon, you approached that question from the perspective of what we should do clinically, and that makes complete sense what you just said. But I just want to know, terminology-wise, do you have a word for these patients who have non-discernible recurrent VF, in that at some point they briefly had a period of asystole and then went right back in? From a research perspective, that group is valuable to separate out from pure refractory. So what do you call them?
I call those recurrent VF.
Okay, so they're all recurrent, whether you can see it clinically or they just have this
exactly.
All right, if you had to separate those out from a research question, the period of recurrence, the period of time before recurrence, we probably want to have some way of speaking about those two groups of recurrent. Have you figured out a way of?
Yes. And we have. So this is what we're just publishing right now. So we're publishing a paper now that looks at what we call the time in VF. And what we know is that time in VF is critically related to neurologically intact survival. So Rudy Koster, his group in the Netherlands published it years ago. And what we saw when we actually looked at some of these files and broke down the files, retrospectively, we saw that patients who got DSED, when they went back into VF, it was much later than patients who got standard defibrillation. So standard defibrillation, you'd come out of VF, and within the first 20 seconds, you'd be back into it. Yet when you had DSED, you'd be 80 seconds into the 2-minute CPR interval, and then the patient would go back into VF. So what we found in this recent study that we're publishing is that the time in VF was significantly shorter for DSED than it was standard defibrillation. And we feel that's actually the reason that these patients actually do better. Their time in VF. VF is the most oxygen-consuming rhythm you can have. So it makes it, as you go longer and longer in VF, more oxygen. It's just, you might as well defibrillate the table. They will not come out of VF. So we found two things. One, time in VF was shorter, and the proportion of patients who go into a perfusing rhythm was much higher in DSED than it was in standard defibrillation. So less time in recurrence, more time in perfusing rhythm. And we think that's critical to why these patients do better, even if they're in recurrent VF.
That's fantastic. And that one you said is about to be published, or that one's already
It's under review right now.
Okay, fantastic. So we'll be looking forward to that. You mentioned see-through. Do you buy it? Do you use it in your clinical practice, or do you not even look?
I'll use it in clinical practice. I did a ton of work on see-through early on when it came out. I think see-through has potential. The trouble is you can't filter everything. And particularly when you have very deep compressions, you cannot filter through. You can think the patient's in asystole, you actually stop and they're in PEA. So the filtering software is good. It's not perfect. So I don't buy it 100% at all.
The way I've been using it is if I see what looks like a perfusing rhythm, I'm going to call for a rhythm check sooner than I would have otherwise, but I'm not going to do anything clinically on that without checking it.
Exactly. That's a great way to approach it. That's exactly how I'd approach it.
The AHA is telling us to get back on the chest immediately after each shock, and this prevents our ability to know this patient might benefit from a second shock much sooner than we are now. And I understand their rationale scientifically why. Is that your opinion? Are we on the right track with that? Or should there be patients who get a second, a third shock with an immediacy after that initial one?
Yeah, I think my time in VF work right now suggests that we should probably shock early. Scotty Youngquist in Utah just published a paper that said pretty well the exact same thing as we found in our time in VF. These patients who go in VF earlier probably should be shocked earlier. The question is, should it be that 5-second piece, right? So we've done work on DAC shocks before, and it didn't seem to make a difference. And the question is, when we actually and my pre-post shock pause work, when we get back on the chest right away, do we actually put people back into VF? And sometimes difficult to tell. And even again, with great filtering software, that first 5 seconds, I don't care what anyone tells you, there's a lot of artifact there to come out of. So it's really tough to know when it comes back. I don't know when the exact perfect time is to reshock again, if it's in the 2 minutes, but that early stack shock work suggests maybe right away may not be the best based on that. So maybe a bit of time may make a difference, but that I think is really, especially with this time and VF work we're looking at, is really an excellent question.
All right. So I listened to your fantastic lecture in Graz, and I'm going to link to that. And that takes a lot of work off my hands because I'm just going to send people there. And this is really going to be an add-on to that. You mentioned that you folks are pretty sure the mechanism is impedance and not vector. Explain that a little bit, and then I'll have some follow-up questions.
I think it's actually both.
Okay,
so
that makes more sense.
To me, there's no question whatsoever at all. The AP is a better vector. And I'm going to start teaching people this. The AP vector, if you look at it to a transthoracic CT, there's no question you're capturing a greater proportion of the ventricle when you actually do AP. And I think when people do AP, they have much more consistent pad position. When you do AL defibrillation, the best part, the AL lateral pad, got to be in the mid-axillary line. The trouble is most people don't put it there. And the further up and down you go from that, the more and more of the ventricle you're actually missing. The ventricles are really posterior structure, so you got to really hit that posterior part of the ventricle to make a difference. Our impedance work, and this is our next paper we're working on now, very clearly showed almost a 30% drop in impedance in the AP plane compared to the AL plane. And the beauty of dose VF is this is coming from the same patient, that this is not artifactual, this is coming from the same patient, and it happened in vector change as well as DSCD patients. So some people said, oh, you're using 2 defibrillators, it's infecting the way they measure impedance. Hey, vector change, you got 1 defibrillator, 1 patient. So you drop impedance by 30%, there's more current going through the ventricle. And current is what matters, not energy, not impedance, it's current. And what if you have for the same energy, you have more current going through the ventricle. So we think that's the big play. So now people say, Dr. C, where should I start? To me, I would start an AP right now. For VF, I would start an AP, and I would go to AL if I only had 1 defibrillator. But if I didn't, I'd go to DSCD from AP and never have a vector change. And that's a lot of my US systems that are doing DSCD begin in AP. And the reason they do is if you have AP with mechanical CPR, easy to put the AP pad on the same time you're doing the Lucas. Then after 3 shocks, simply you put on the AL pads, and you don't have any CPR misses. You don't have any degradation in CPR quality. It's easy to do. In our trial, we started AL and then went to AP, but I can see the benefit of doing AP first.
You just anticipated like 3 of my questions, and I was the exact same thing. So that's fantastic to hear we're on the same page. Let me make sure I've disambiguated this for the audience that may not be as familiar with all this. So what I'm hearing you say is that AP is less impedance, even if it was given right from the start, that it's going to be more current delivered from the heart than AL. 100%. So I'm right on that so far, right?
So and I think the new ILCOR guidelines suggested AL before AP. And I wrote my comments to them that I totally disagree. And the reason they felt AL should go before AP is because of speed.
Yep.
But hey, listen, look at the recent IO-IV trials. We thought all IO was quicker than IV. That didn't work out. So until you study it, you don't convince me. And I think we have to separate out speed versus efficacy. If I get a pad on quickly, but it's in a poorer direction of the fibrillatory shock, that necessarily is not efficacious. And that's why I believe AP should be the starting point.
That makes complete sense. Now, if we take that a step further, then what you are saying is that the vector change, its only advantage is that now you're putting pads in the superior position to deliver current to heart. Was there any other putative benefit to the vector change? Was the previous shocks potentially lowering the impedance to the chest from the shocks themselves rather than the position change?
So that is true if you keep the pads in AL. There's well-documented animal data that if you keep the pads in AL, the impedance will slightly drop for repeated shocks, but not to the extent that we saw in AP. And Scott, this was consistent in every case. It was pathognomonic that the patient was getting AP defibrillation. You would see this impedance drop. I think the repeated shocks in a single position will definitely slightly lower your impedance, but nowhere near the degree of moving the pads to AP.
All right. So then what I'm hearing is if we start with AP, which I think is what I'd advocate, and it sounds like what you're advocating, then vector change is gone. There's no benefit to vector change at that point. Is that correct?
I know. So I think the only benefit to vector change is if you have a single defibrillator, it may be something to try. But personally, I would do repeated AP shocks, because I just think the decrease in impedance is too much to ignore in terms of the benefit of that particular position. And I just think getting that AL position consistently right by everyone is much more challenging to do than the APs. One of the ways you actually prevent refractory VF is preventing from going into it in the first place. And if we start an AP, we may actually have less refractory VF than we're seeing now.
I love it. All right. Why are we, if impedance is so important, why are we not pushing on the pads like they do in the EP lab, using a non-conductive handle or something, or a glove box, and further decrease the impedance?
There's no question. So there's no question. You put pressure on the pads, it'll improve it. I'll tell you a funny story. So there was a trial in Australia looking at exactly this question. And what happened was, during one of the processes, the paramedics said they were shocked by doing this. This spread through the service. The trial was stopped right away. And it reminds me of my early work on hands-on CPR, where I said we could shock through this. And again, makes great sense from a physiology point of view. You just take one person to get shocked, and then people will say it's not safe, and that's the issue. So there's no question, pressing on the pads will decrease impedance. In the trial that was going to look at this question, this is why the trial was stopped, because the paramedics said that they were shocked by this. Whether they were or not is up for grabs, but there's no question that will improve, that will decrease impedance as well, no question.
So if you had, we do, because I put a case report in resuscitation of me getting shocked because I had done like 100 of these with my hands on, and it wasn't a dangerous shock. But so what we do is we kept around some of the old defibrillator paddles without wires, and we just use those, and there's no chance of us getting shocked.
That's a great idea. That's a great idea.
But okay, so now we understand the mechanism then of why vector change works, at least by your estimation. DSD, or as you call it, DSED, is that working because now you're getting the impedance benefits of being AP and you're hitting more of the myocytes? Is that the mechanism?
And that's the key. The key with DSED is you get a much more homogeneous distribution of energy across the ventricle. The reason patients go back into VF is you're not defibrillating every myocyte. And I think the thought that biphasic defibrillation was the cure-all and end-all of defibrillation was, in my mind, a failed hypothesis. To me, I think we fell asleep on biphasic defibrillation. I think we had biphasic said, oh, this is the be-all and end-all, and I don't think it is. And I think there are better ways, and I think the future will be a single defibrillator, 4 pads, press one button, and you'll get DSED. And you'll have that optimal time interval between the shocks. I think if we see some confirmatory studies in Europe that confirm the benefit of DSED, I mark my words, you'll see that in the future.
Absolutely. All right, let's talk a little bit more about mechanisms of lowering impedance. A lot of us are using mechanical CPR. I think it's crazy to still be doing hand CPR in the hospital, just from a human factors perspective. It changes the entire nature of the code. There's no reason they couldn't have the shock delivered on a downbeat of mechanical CPR, which is going to have a much compressed chest and, again, lower impedance. Has any work been done on that?
Yeah, I think there's a lot of the defibrillators will actually do that. So both Zoll and Stryker have defibrillators that can do that, where you time that. So I think that should be coming if it's not there already. But that makes perfect sense for the exact same reason that you brought it up there.
AEDs were used in the dose VF trial in some of the patients. Now, AEDs have a long hands-off time while they're analyzing, stand clear. Do you think the results would have been even better if it was manual defibs across the board?
I don't think so, because to me, defibrillation is defibrillation. Okay, so what we've done is we've done DSED. One of the big questions was, did you have to have 2 manual defibrillators to do DSED? And what we've done is we've done DSED with manual, AED, AED manual. We've done them all. And I think the key thing is you have to synchronize the charging up phase of the AED so it happens at the same time as your analysis would happen. So what we do is if we have a manual defibrillator on and then we add an AED, we actually only turn on the AED when there's, let's say, 15 seconds left in our 2-minute CPR cycle. So then by the time the defibrillators and the analyzing, we've completed our 2-minute CPR cycle and they're synchronized. So we have all these teaching videos on our First 60 website that shows everyone how to do it with mechanical, AED. We've done them all and they all work. So to me, it's more important that you deliver the SED shock than what is delivering the shock. And many places wonder, you know what, the cost of 2 manual defibs in a vehicle. We have services now that are doing a manual and an AED in their truck. So actually, you have both of them at a lower cost, and this makes it much easier. People always say that you have to do, the big thing about doing DSED is you need 2 defibrillators. 2 defibrillators to me is much easier than putting together a whole system of ECMO for refractory VF. And we use fire defibs. We use our police defibs.
Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
So we have all kinds of defibs. So we never had an issue of having 2 defibs on the scene.
This is where I'm going to really ask you to just verge to go into your opinion mode, because I know I've heard what you said at the lecture in terms of this, but I'm curious to hear what your heart says. So in 2025, should we be waiting for the forced shock to administer DSD?
No.
Okay, tell me.
No question.
When would you do it?
No question. So there's 4, I'll bring in the European studies so you'll know what they are. So in Sweden, they're looking at the study of the DSED versus standard with DSED after the first failed DMS shock. In Norway, they're doing a trial looking at DSED versus standard with DSED as the initial shock. So people say, wow, that's crazy. So Norway is the only area in the world that does 3-minute CPR cycles. So they felt because they do 3-minute CPR cycles, that'd be too long to delay DSED. The Danes are doing DSED versus vector versus standard after 1 failed DMS shock. So these are all looking at a different research question. They're looking at early DSED versus DSED for refractory VF. And the German study is DSED standard after 3 failed shocks. So almost more of a confirmatory study. The reason I do believe DSED will be successful early is when we look at our analysis of our data at ROSC and survival and related to shock number, the huge benefit of DSED was at shock 4. So the first shock, we were seeing 75% ROSC rates, 70% survival rates. And if I take into account our data on time in VF, by shortening the time in VF and doing DSED earlier, I think you will see a benefit. Personally, I would do it after shock 1 or shock 2. I would not wait till shock 3.
We have data from the EP lab demonstrating that just increasing current does not hurt the myocytes. Aside from logistics, is there any reason we should be administering any shock besides a DSED shock?
That's going to be the future. I think what you'll need is confirmatory data to show that. I think when you're looking at an RCT, it's a little bit different than common sense, right? So you look at an RCT, you have to actually plan a sample size based on the higher survival rates after shock 2 for superiority. But intuitively, based on the data that we saw from DoseVF, I do believe these studies will be successful if they're carried out in the same way and the same rigor that we've seen.
Now, you had mentioned in the lecture that if you were going to do DoseVF2, it would just be vector change versus DSED. Is that simply because you want to confirm the results of the original trial? Because it seems like now the vector change becomes the placebo. So is that the idea?
I think the people, I think the real scientists feel that vector change is embedded in DSED. So they really wanted to be able to tease that out. And because the trial didn't look at that direct comparison, we're never powered to, it's not a purpose of the trial, people are interested because vector change would only be one defibrillator, DSED is 2, maybe a little bit easier to do. So I think there is some scientific interest in that. It's very interesting that none of the trials were interested in that question. So I think most people who are clinicians out there have already bought the fact that DSED works. Now the question is, does it work earlier? So I think that's the issue.
I would love to see just AP versus DSED. Yeah. That would be the trial that I'd be interested in.
Yeah, exactly, as opposed to vector change.
Yep.
Yeah, that would. And so I think what's going to be interesting is looking at some data from sites now that do PA or do AP as their DSED as opposed to AL first, right? That would be interesting to compare. Again, not a question we looked at, but I think that would be very interesting.
All right, let's shift to the manufacturer side of this. Now, you said in your lecture you didn't blow up any machines, but that is less my fear. There was a case report published talking about DSED being done with 2 machines, and then one of them testing fine on the daily nursing checks, but then not actually delivering energy during defibrillation. So this kind of hidden, latent threat. How do you know that didn't happen? Were these machines all doing bench testing afterwards to figure out that they were still delivering the energy?
So we never did any bench testing after. We tested it after. Paramedics did a self-test after, and then the logistics did a self-test before putting the defibrillator back in service again. So they'd come in at the end of their shift, and that was it. I can tell you right now, this whole thing about damage is, in fact, the biggest impedance to the use of DSED is Stryker. You said you wanted to.
Okay. Totally allowed.
So it is not about science anymore. Okay. I think there's plenty of people who have accepted the science. The Stryker Corp had a letter out to their services saying that if in fact the defibrillator was damaged doing DSED, they wouldn't honor the warranty. That's actually kept a large number of people who are interested in doing DSED away from doing it. We've published work already looking at this. We have not found a single evidence of any defibrillator damage doing sequential DSED. There's never been a case report in the world. The case report that you're referring to was actually in Annals, and this was a case of double sequential cardioversion using a Zoll and a physio defibrillator for someone who was in VT with a pulse, so hypotensive with VT, and the pad placement was not in the orthogonal position that we have the pads in. And these are very key points. So the key points is, where are the pads if you place them in the position that we put the pads in? So if you sequentially do the shock as opposed to simultaneous, there has never been a reported case. And the defibrillator manufacturers know this. The time frame that we use, we've timed this out. In the trial, it was 600, it's just over 600 milliseconds. That's to actually damage a defibrillator, you almost have to hit them to the millisecond. And if you have about a 200 millisecond window, in theory, that you can actually have the shock go through the other defibrillator. My point would be that if you do sequential DSED, there is zero chance of risk. The defibrillator manufacturers know this as well.
That makes complete sense, but we're bordering these secondary analyses that send us in 2 different directions then, because in DoseVF, there was this 1 second pause between the shocks. So it was truly sequential. And when I read the trial, what I started doing is I'd count down 3, 2, 1 shock, and then I would shock on 1, and then I'd have my partner shock on shock. But then the secondary analysis came out saying the closer we get to simultaneous, the better it is, which means like I threw that out the window. Now, look, no two humans could actually get simultaneous, but you could get close. So I believe you completely. Sequential ain't going to hurt the machines. Will an attempt at simultaneous hurt the machines?
Yeah. So I think simultaneous is likely more effective with a very minuscule risk of defibrillator damage. And we have that risk in our survey. It was about a 0.05% risk of defibrillator damage. And again, defibrillator is not the defibrillator blowing up. You reset the motherboard, the defibrillator goes to work. The bigger concern, is it available to the next patient should you have another case? So that's one I think. And I think, Scott, the interval may be different between two defibrillators. And the reason why I tell you this, I think the Zoll defibrillator is more impervious to damage. And I think it's because the waveforms are different. And you may have read the paper on atrial fib cardioversion that was presented in New Orleans last year, where they looked at synchronized cardioversion using two Zoll R series defibrillators for patients with large BMIs in atrial fib. And they did synchronized cardioversion on these patients, and no one did not come out of AFib who did a double sequential. And these were synchronized. You can't get more on than synchronized. Not one defibrillator was damaged. So that tells me that the timing interval may actually be different between the two defibrillator types based on the different waveforms. So I think that's a very important piece. So I think that if we develop a defibrillator that's able to provide 4 pads in a perfect time interval between that interval may be different depending on what the waveform that you use in the defibrillator.
If that makes sense. It was baffling to me that the manufacturers had any problem with this. They should have been running for you to do this trial, because if you believe the results, and I certainly do, then it means they're going to have sweeping replacements of all their machines when they develop one capable of doing dual sequential with one machine. And this has the potential to make them millions. What do you posit the short-sightedness of Stryker in this regard? They're to kill your trial would be to lose the potential for enormous profit.
You know what I think, Scott? I'll be honest with you. I think there was a lot of what I would call poor observational study before this. There was a lot of animal studies that suggested that perhaps DSCD wouldn't work. But these are animal studies, not human studies, okay? We were the first randomized controlled trial in humans to show a benefit. I think many who were, I would say, the DSCD naysayers already had positions on DSCD prior to the trial. Hence, when the trial results came out, you have a choice. Do you believe new science and take another look at your position? And most did, but there are still some who still did not believe the results. And I think that's why people are still looking for the confirmatory study. I think there's plenty of podcasts. I've given this talk, Scott, 200 times since the trial. And even 2 years after, we're still booking 6 to 8 months ahead of time to give talks on this. So there's tons of interest in it. I think the issue becomes, if I was to be critical of the trial, it's the only trial. It's the only trial. Anytime you have a single RCT, you want to see it confirmed. The issues around stopping earlier, the other issues that people picked up, we have answers for all of that. But if I was going to be critical, it's the only trial, and we'd love to see it confirmed. I think the defibrillator companies were more anxious because this was an off-label use of their device. So whenever you have an off-label use of the device, a defibrillator company cannot support that in their advertising per se. And I still think that's true. But it's interesting. If you look at Zoll Medical now, their letter to their customers is very good. It says, this is an off-label use of the device, but if you're going to do it, here's what to do. Here's where to put the pads. Here's how you do the shocking. And they don't even mention the warranty because they know if you do it like this, it's not going to be at risk to the defibrillator. So I think that's what I would love to see Stryker move to that position. But to my knowledge, they have not yet done that.
The first to market with a machine that's actually capable of doing this with one machine, I think no one would choose to buy one that doesn't have that if that's available on the market. So
I agree.
I can't understand their short-sightedness. Does 360 joules biphasic matter? Is that going to be the new standard or? No,
I think it's all waveform. 360 BTE versus rectilinear, they're all the same. So it's the transmyocardial current that matters. It's not the energy. So I think There's a lot of people say, hey, just dial up more energy. It's not up energy, it's current that really matters.
Now, you have mentioned in the talk, and I'm super curious about this, that dual sequential was not just better at getting them out, it was better at keeping them out. And tell me a little bit about the mechanism of that.
Yeah. So I think that's all related to time and VF. I think what happens, and we saw this with the vector change arm, we saw the survival rates were about 10% absolute difference in the trial. When we look more closely at it, what we saw is that you'd have more recurrent VF with vector. So with vector change, people would get ROSC and then they would rearrest. So that told us that, yes, the vector made a difference, but some cases just need more current as well. So I think that's where the DSED makes a difference. So again, this time in VF, you look at a 2-minute CPR cycle, 20 seconds, you're back in VF with standard. 80 seconds, you're back in VF with DSED. And we have beautiful sort of violin plots in this paper we're showing that really to the eye show you the difference. And they really are much different depending upon the defibrillation strategy.
But is the putative mechanism that there is some latent VF hanging out there?
There's some latent VF, and there's portions of the myocardium that are not completely defibrillated. And it's really interesting when you see some of these, Scotty, when you see some of these patients who get ROSC, people say, okay, you give the shock, and then the patient already gets a nice perfusing rhythm. There are many patients who you give the shock and you annihilate every myocyte. Patient goes into asystole, and then as the pacemaker kicks in, you see a beautiful QRS complex and the patient regains a pulse. We don't know why one does it and why the other doesn't, but I think the defibrillation of more myocytes is critical to DSED success.
Now, we know in the resuscitation and ECMO community, there hasn't been enough work published on this, but all of us, I think, in the community would assert this as being truth in the world. The outcomes are completely different with intermittent ROSC and non-ROSC at any point during a code for the codes of the same length. You could have a patient 45 minutes out, dismal neurologic outcome, but 45 minutes with a few episodes of intermittent ROSC, an entirely different game. Do you feel that's where a lot of the neurologic benefit from this came from?
100%. And we saw this. So if you look at there's a nice paper in Critical Care Medicine that looked at the Prague study, and it looked at the outcomes neurologically if the patient got ROSC, if the patient had no ROSC in ECMO, and they had no ROSC in ALS. And what they found clearly is those patients who had ROSC had superior neurological outcomes. So what I always like to say is I think ECMO is great. I think it's cool. ROSC is better. ROSC is the key. And I think DSED is better than any other defibrillation strategy at getting early ROSC. You get early ROSC, you minimize low flow time, you improve neurological outcomes. That's really the key. So anything we can do to get ROSC early is very important.
It's so funny when in your lecture you mentioned that people are raising an argument of DSED versus ECMO, and that you and I completely agree. That's completely missing the point. They are not
totally
in any way in opposition. And my prediction of the future is in 10 years, many of our cardiac arrests, even that get ROSC, will still go on to ECMO because it's not getting them out, it's keeping them out for the next 3 days that really matters. So I would much prefer to have a patient who got spontaneous ROSC after DSED and then put them on ECMO than have to have a patient 65 minutes down.
I guarantee, and all the ECMO specialists, so if you talk to Dimitri, you talk to Lionel in France, they're all the same. Many of those trip programs now have gone DSED first prior to ECMO.
Yeah, absolutely.
So I think that, and I think that makes total sense for these programs.
Sheldon, what should I have asked you that I missed that you want to get out there about defibrillation?
You know what, Scott, that was one of the most all-encompassing. I've done a ton of these. You asked me all the really great questions in terms of the controversies, I would say, the issues of ECMO refractory versus recurrent VF. We touched on time in VF, which is this newest data that is coming out. And we touched on what I thought was the most controversial was AP first versus AL first, which I think Josh Lupton and Mo Daya's work published in JAMA that looked at their paper in Portland and clearly showed that AP improved ROSC in an observational study. That adds to our data on our impedance and really adds to that. I think at the end of the day, the one question you probably didn't ask me is, do you think this is going to be in the AHA or in the ERC guidelines? Because many people around the world are very guideline focused, in particular in Europe. So almost all my talks now are in Europe. And the reason they're in Europe is because the ILCOR guideline changes. When ILCOR changes, it's very rare to ERC and AHA to not follow those guideline changes. So I suspect you will see guideline changes. What I would say to you, though, is that I think there's lots of smart clinicians out there, and many of them have made their decisions regardless of the guidelines. So the guidelines are great, but clinicians are the ones who make decisions, not guidelines. So I think you will see these in the guidelines. Will they have the level of evidence of others? Probably not. We argued at the ILCOR guideline that it should have been higher than what it was ranked by grade, and we have many grade methodologists on our group. But really, at the end of the day, the level of evidence they gave DSED is exactly the same as epinephrine, amiodarone, and ECMO. And epinephrine, amiodarone, everyone uses those, so it makes sense that's what people would use. So I think that you will see those in the guidelines, but guidelines in and of itself are not the final determining factor. Clinicians are the final determining factor. I think the other thing that I think you probably didn't ask is, do you see this being a purely pre-hospital phase, or is it an in-hospital? And most of my talks now are actually to emerge ICU critical care. It's hilarious. They're not to EMS anymore. So I think it's really rare, Scott. EMS almost always takes their evidence and their procedures in their field from in-hospital care. Dose VF is one of the first times that an out-of-hospital study changed in-hospital practice. It's almost impossible. That's almost never happened. So listen, you know what, Scott, at the end of the day, I get 2 or 3 emails every week from clinicians around the world. They say, thank you so much for this study. You saved the life of one of my patients in refractory VF, and we never would have done dose VF if not for that. That makes me happy. That makes me feel that we've really accomplished something.
Can't think of a better place to end than that. I cannot thank you enough, Dr. Cheskes. It's just so fantastic to talk to you. You are a wealth and font of information.
Thank you so much, Scott. It's been a huge pleasure and an honor to be on your show today.